Well, good morning. This is my PhD topic that I will introduce you today, which is conservative therapeutic approaches to restore enamel lesions and defects. So I'm Bianca Golzio, and what I envision as a PhD student is to translate clinical problems that we have into high-level science and also contribute to better health decisions through minimally invasive dentistry especially. In that way, we can preserve healthy and natural tooth structure. So my mission is to truly bring to clinical practice the possibilities of non-invasive approaches for dental enamel problems. So in order to achieve this mission, my main goal is to bring CPP-ACP, which is a very promising agent for remineralizing, and understand its efficacy both in caries lesions but also in developmental enamel defects. So my first topic is efficacy of CPP-ACP on remineralization of white spot lesions compared to fluoride therapies alone. So until the 90s, there was a reduction of 90% in the caries prevalence experienced, especially in high-income countries, after the widespread use of fluoridated toothpaste. But still, despite of this, I must highlight that according to Global Burden of Diseases, dental caries that is untreated is the most common health condition, so it's #1 problem. We have 2.3 billion people who have caries of permanent teeth and 530 million children who have caries of primary teeth that are still untreated. Therefore, we need to further develop strategies that need to enhance and improve the efficacy of fluoride and also address its limitations, especially in early stages of caries and for its prevention. So CPP-ACP is a product for that. It's actually a product that is derived from the milk protein casein, offers no harm, and can reduce up to 58% of caries lesion area after 4 weeks of use. So our aim is to evaluate the remineralization efficacy of the combination of CPP-ACP and fluorides versus fluoride-only interventions. So our clinical question is if this combination is truly more effective than fluoride alone. And for this, our population will be the patients with white spot lesions, which are the early stages of caries lesions, which are not yet cavitated. And our intervention will be the CPP-ACP agents plus fluoride use, and we will compare this to fluoride-alone therapies. And our outcomes that we will measure is mainly remineralization efficacy through QLF and LF. So our hypothesis is that these agents plus fluorides are indeed more effective. So our clinical implication that we aim to reach with this study is to halt caries lesions and its complications and also provide their remineralization. That way we can avoid invasive therapies through an easy, safe, and cost-effective approach. For that, we did a systematic search in main 3 databases, as we can see here. And we had, at final, 21 eligible full texts. And we have some preliminary results. We still have other results that are under analysis of other outcome and other time points as well. And here we can see the comparison of laser fluorescence at the time point of 3 months. And this data here we can see by their common effect that both either CPP-ACP and CPP-ACFP, which is a CPP-ACP who already has built-in fluoride, they both show significant results when they reduce it, the demineralized area, and we can state that this could be a very effective remineralizing agent that can have and provide an added benefit to the fluoride-only effect. Our strengths, our main strengths are that we used only RCTs, and we had significant results separately just from the CPP-ACFP group compared to control, and different from other previous meta-analysis, we did the analysis by time points. So we didn't group all of them together, and we can see better and understand this efficacy at a long run. And for limitations, this is still a short follow-up time. We have other time points with 1, 3, 6, and 12 months that we should further analyze. And also another limitation was the high heterogeneity of the CPP-ACP studies, as we can see in the first subgroup. My second topic is the role of CPP-ACP on remineralization and hypersensitivity management in teeth affected by molar hypomineralization, which is MH. MH is a qualitative developmental enamel defect that is clinically seen as demarcated opacities that range from white to yellow-brownish color and also range from severity, as we can see in these pictures. In order to diagnose it, we need to have at least one permanent molar that is affected, with or without the involvement of the incisor. So MH nowadays have a global prevalence of 12.9%. And of MH-affected teeth, 27.4% did or will require the need for treatment. And this is mainly due to two reasons: pain and sensitivity, and also post-eruptive breakdown. The increased sensitivity that these patients show leads them to a poor oral hygiene. They often have higher plaque accumulation and also a higher susceptibility to caries. Beside this, these patients already have an increased anxiety and also a lack of cooperation in the several treatments that they need. And the less mineralized enamel is less resistant and more prone to breakdown. That's why we need to further develop other strategies than just a restorative approach in order to provide these patients a better care and also prevent further complications that might happen from MH. So CPP-ACP can reduce sensitivity and also increase the mineral density of enamel. And that way, it can address the limitations that I have previously mentioned. So our aim is to understand to what extent CPP-ACP can really increase the mineral content and also reduce hypersensitivity in MH-affected teeth. So that's why our clinical question is if CPP-ACP is effective on increasing those two outcomes. And our population are the patients with MH-affected teeth that are using CPP-ACP agents, and we will compare them before and after treatment. Our main outcomes will be remineralization by KLF and LF, and also sensitivity through SCAS and VAS index. Our hypothesis is that CPP is actually effective on those outcomes. And what we believe that we can do is the improvement on managing the way that we treat patients nowadays, and also the prevention of MH complications through an easy and safe approach, and also cost-effective, that is CPP-ACP. So here we can see the systematic search that we have done. It is a narrow pool because this is a new topic that is not further investigated. And this is an overview of our planned submission date for both the projects, which are March and June of next year. And I would like to thank you for your attention and leave you with a quote by C.S. Lewis. You can't go back and change the beginning, but you can start where you are and change the ending. Thank you very much.
Hi, thank you very much for your presentation. I have a question about your background for the first presentation. Mm-hmm. So the incidence of these dental caries, mm-hmm. it correlates with deficiencies in public health. Do you think that CPP-ACP is superior to fluoride and fluoride-containing toothpastes? So, for example, if all of these people who don't have access to hygiene products, to clean drinking water, is it a better idea to somehow logistically bring them CPP-ACP instead of a fluoride-containing toothpaste? Mm-hmm.
Caries is actually a multifactorial disease, so we cannot only say that it's fluoride that will solve the problem, and neither just prevention, because it's also the environment that you have. You need to have bacteria, you need to have a poor hygiene, and also you need to have sugar there, so carbohydrates for the bacteria to be fed. So this is not a matter. What I propose here is not to substitute fluoride, but also have something that is additional to it, because fluoride toothpaste isn't in our daily basis life. So we all brush our teeth with fluoridated toothpaste, and this is good. But here, when I show this data, I want to show the need of still developing other agents, and CPP seems to be a great product for that. So it's just an idea of having something additional, and we will keep progressing like this.
Thanks. Thank you.
You're welcome.
My question actually is somehow related to Johnner's question, which is, you mentioned high heterogeneity on your forest plot. Don't forget that that's statistical heterogeneity, and it's not necessarily equivalent to the clinical heterogeneity. Yes. But I think Johnner already highlighted a part of the possible clinical heterogeneity behind these results, because as you can see, for example, the study of, sorry, I cannot read the fifth study, probably shows quite the opposite result. And did you already find other causes for this heterogeneity, or what do you think besides let me say, the country where the paper was published? Of course, there are public health differences. And
I would say especially age, because we have papers that were done with people from 15 to 21 years, and we also have with 2 to 3 years old. So this might be a very good cause for heterogeneity. And also even the application, especially for CPP-ACP. Since it is really easy to use, you don't need professional supervision. So some of these cases, it was done in schools, for example, to the 2 to 3 years. So even though that those teachers were taught how to do the application, we cannot know for sure how they did. So we have these clinical situations that might have happened.
Well done, beautiful project. I'm no dentist, so I need a little bit of understanding here with my question. What is LF?
It's laser fluorescence and quantified laser fluorescence. So these are two ways that you can measure. So you measure by shedding fluorescence light, and the LF is measured by 0 to 99, and the higher it is, the deeper is the caries lesions. So we can actually see how much it was in the beginning and how much it has decreased.
Does it have a measure?
Yes. Yes.
And so you can detect a statistically significant difference in the second group of patients with CPP-ACP.
Yes.
But is that clinically relevant difference of LF? See what I'm asking. So yeah, statistically it's -5.
They have mentioned to be different clinically, especially if we think that we are using only one way of putting fluoride there and we have an additional one. I mean, if we think practically, we know that we will have a difference clinically. So sometimes it's hard to show what's clinically different in statistics. So I believe we have both here.
So my question is, with that improvement, can I expect less caries? How closely is LF related to caries? That's my.
Sorry?
How closely is LF related to caries? That's my question.
It measures the size of the caries, let's say, the size of the lesion area. So when I have a lesion that is a 10 size, and then after the use of this determined product, I have a smaller lesion, so I can understand that the lesion, that the area that was demineralized before is remineralized. That's why we are measuring here remineralization efficacy to see what was sick, how good it is now. So
okay.
This is basically what we do.
Okay, I understand now. Thank you very much.
You're welcome.